past president of the International OCD Foundation. She currently serves as its secretary, and she's been a member of the board of directors since 1998. Please join me in welcoming her here tonight.
Thanks. Well, it's nice to be here and to be talking about Pandas, pediatric autoimmune neuropsychiatric disorder associated with strep. So you can see why they needed a nice, catchy acronym for that because it's a mouthful. And it's interesting because I don't treat kids, so it's funny that I should be talking about this particular topic. But it really came out of my work with the International OCD Foundation, and over the last few years, we've really been on a pediatric push, if you will. I think really targeting pediatric OCD as one of our pet projects, and I think that for good reason. You know, I think although raising awareness in general is one of the key missions of the organization, I think that obviously targeting awareness and diagnosis of OCD in childhood is especially important because obviously the earlier you can intervene, diagnose, and treat any illness, the better. And so we really feel as though pediatric OCD has, sort of been something that's been somewhat overlooked over time and something that we wanted to pay even closer attention to. And, Pandas really falls under that category. So, over the past couple of years, there has been a page added to our website that's been specifically devoted to Pandas. Last year, I know that Dr. Jeneke did a couple of public service announcements specifically about Pandas. One for just sort of people in general, and then one that was dedicated to the medical community. And so it has been a subject that's been of interest to us, and that was sort of how I got interested in it as well. So, I'll preface all of my entire talk tonight by saying that Pandas in general is very understudied. If you sort of look in the research literature about Pandas, there really is not much there. I think there was an article written a couple of years ago that said that there was probably just over 200 articles written about Pandas, and that a lot of these articles were about one patient or very small groups of patients, often about the same patients. But that if you go online, there are over 100,000 internet sites that are dedicated to the discussion of the relationship between strep infections and OCD. So there's obviously a huge gap between the public interest in Pandas and what is conclusively known about it in the research literature. And it's, again, our hope that increased awareness across multiple arenas that will begin to close this gap, and that the research about the connection between infection and mental illness we'll begin to know more about that, and that we'll be able to help kids and their families that struggle with this in the process. So, a lot of notes here. Part of what we're going to talk about tonight is just a little bit of history about Pandas, how to recognize a Pandas child, some of the etiological factors, and then some recent changes to the Pandas diagnosis that have occurred over the past year or so, a little bit about testing and treatment, and then sort of depending on time, we can talk about a couple of case examples as well. So, how did all this get started? A woman by the name of Dr. Sue Suedo, who was working at the National Institute of Mental Health, and when you talk about pandas, it's hard not to talk about Sue Suedo, who really is the pioneer of pandas research. But in the late 1990s, she was studying two parallel groups of children. One group of children had something called Sydenham's chorea, which is a movement disorder that results from strep infections that is associated with rheumatic fever. And the other group of children had OCD. And in the OCD group, what she noticed was that there was a subset of patients that had what she described as an explosive or overnight onset of OCD. And these were kids who essentially went from having sort of little to no OCD symptomatology to meeting the full criteria for OCD over the course of 24 to 48 hours. So when we talk about, sort of an explosive episode, that's really what we're talking about. And then after this explosive episode, that would be followed by a relapsing and remitting course. And Sue Suedo described this as sort of, if you charted it out, as having sort of a sawtooth pattern. So what you would see would be these very dramatic, explosive episodes of symptoms, and then the symptoms would remit, sometimes for long periods of time, and then you would see, again, another explosive episode, and then another remission. And what she really noticed, comparing this subgroup of children against the other group of children with OCD, was that they didn't really match up, that the other group of OCD children had a more traditional sort of undulating course of symptoms where there was a more gradual onset and a waxing and waning course, so sort of a wavier course of symptoms rather than this sawtooth pattern that she described. And the other thing that she noticed was that the symptom relapses often occurred after strep infections. And that the OCD group findings closely paralleled those from the Sydenham's chorea study, where 60 to 75% of the children with Sydenham's were noted to have OCD symptoms. So again, she's looking, I think it's something that may have been a little hard to follow, but she's looking at these two very different groups of children with two completely different disorders, but then just observationally noticing that this Sydenham's group, which is an illness caused by strep, has this huge percentage of kids that also have OCD. And then in this OCD group, this subset of kids that gets this explosive overnight development of OCD symptoms that seems to follow strep infections. So she sort of notices this kind of parallel between these two groups of kids. And interestingly, what Sue Suedo also noticed was that strep was not necessarily the only infectious trigger of this explosive overnight OCD symptom, but initially she had a different acronym, which I won't confuse you with, but it was meant to encompass other infectious triggers. But and at the same time, there were other groups outside of NIMH that were also noticing similar relationships between strep both strep and other infectious triggers and OCD. So Sue Squado was not the only person at that time who was noticing this connection, but she was really the one who was writing about it. But what was clear was that they didn't really understand the nature of this association, what they were observing. They couldn't really be clear whether it was actually the infection that was causing the exacerbation of the symptoms. And so she really decided to study it in a more scientific way. And as she did that, she really began to decide how to narrow her focus for the study. And what she decided was, because she had already done so much research on these Sydenham's chorea kids, that was already a disorder that was linked with strep, that she would sort of piggyback this OCD study onto what was already known about the Sydenham's group and limit it to kids to which there could be this association with strep infections only. So even though she really felt that the OCD onset could be related to other infections as well, she really decided at that time to limit her study to kids to whom she could trace this explosive onset of OCD to strep infections. And that was how Pandas really became, associated with strep infections only. And, really how Pandas came to be. Talk about the clinical criteria for Pandas. And there are 5 of them that you need to meet in order to qualify for the diagnosis of Pandas. So the first is having OCD and or a tic disorder by DSM-4 criteria. So again, the inclusion of tics is important, and I'll point it out here and talk about it more a little bit later, but it's important to note that OCD and tics were included in this original criteria for Pandas. That the onset was in childhood, between the ages of 3 years and the onset of puberty. And the reason that they picked that age group was because they felt that they could really capture the majority of kids that would have this abrupt onset, because that's really when you would see most kids having strep infections, is during that kind of age group. Now we know obviously that people that are mostly older than that do get strep infections, but by and large, it's people within that age group, kids within that age group, that get strep. And number 3 was really, again, sort of the hallmark or the most clinically descriptive characteristic of these kids, this abrupt onset of symptoms and the episodic course of symptom severity. And the 4th criteria, the onset of symptoms and or symptom exacerbations were related to strep infection. And again, with the criteria, this criteria, it was on 2 or more occasions. And I think by making it on just more than one occasion, what they were trying to rule out there was just some sort of coincidental association with strep. I think people generally know that lots of kids get strep infections all the time, and that they wanted to make sure that the relationship between the infection and the onset of the disorder were truly related to the strep, and that a one-time association wasn't enough to make that association. So they wanted to make sure that it was happening at least twice, and if not more times. And they would do that by strep testing at the time of infection, or by drawing anti-strep antibodies, both at the time of infection and then usually 6 to 8 weeks later. And then finally, the presence of neurologic abnormalities during the period of symptom exacerbation. And these could include a whole host of things, but primarily they would talk about significant separation anxiety, handwriting changes, and other school and cognitive problems. What you would see, and I guess important to point out, is that these would be significant changes from the child's baseline. So these, again, would be kids who would have been doing very well in school, or would have been average students, and then all of a sudden, at the time of the onset of the OCD symptoms, you would also be seeing significant changes in their school performance, changes in their handwriting, changes in their artwork, and changes in their cognitions in general. So changes from baseline. And also urologic problems. So a sudden onset of nighttime bedwetting or daytime urinary frequency that could not be explained by other kinds of issues, like a UTI or something more benign. So when they tried to think about what was causing pandas, they really went back to, again, earlier studies of things like Sydenham's chorea that are autoimmune processes where antibodies to the strep bacteria were attacking sort of normal neuronal cells in the body. So, I think as people know, when you have an infection in your body produces antibodies that are supposed to attack the bacterial cells to get rid of them. But in autoimmune processes, what happens is the antibodies mistakenly attack, healthy tissue in your body. So in rheumatic fever, they attack your heart tissue, your joints. And in Sydenham's, they do attack the brain tissue, which is what causes the movement disorder. And that was really what the theory was behind pandas as well, that the antibodies to strep were crossing the blood-brain barrier and attacking the basal ganglia, which is the portion of the brain that that affects movement and behavior, and that it was causing inflammation. And they didn't really know, and I still think it's very unclear, how the antibodies are crossing the blood-brain barrier. The blood-brain barrier is normally supposed to be sort of impervious to things getting across, so it's not clear exactly how that's happening. But it is clear that in Pandas patients, you do see larger basal ganglia volume that suggests that it is inflamed in these patients. And one of the criticisms, I think, early on of the pandas etiology and sort of the premise of that was that they had not been able to show it in an animal model or in animal studies. But in 2009, a woman named Maddie Hornig from Columbia was able to show in a mouse model that the passive transfer of strep antibodies caused mice to have behavioral problems that were similar to pandas. So it was an important study because it was really the first time in an animal model that they were able to show that just the antibodies themselves, so these weren't mice that had strep, they were just sort of injected with just the antibodies themselves, and they were shown that the antibodies alone caused these pandas-like symptoms in the mice. And it was the first time that they felt that they were able to show this autoimmune process in an animal model. So obviously studies like this need to be replicated and there need to be more of them, but that had been a huge criticism before this time. So, I think without getting too derailed, we can talk a little bit about the fact that, and just sort of pause a little bit. So Sue Suedo had devised this very nice criteria of pandas that seemed relatively straightforward, but I think what people learned as they began to try to put it into practice was that it was more challenging than she, I think, initially imagined that it would be to actually implement in the real world. That kids were showing up at their doctor's offices, usually well after the fact that they may have had strep, so doing strep testing at that time was no longer effective, so it was challenging to show the association to strep. And there was a lot of controversy about whether or not Pandas was a real disorder. I think that there was a lot of back and forth between various groups of doctors, pediatricians, neurologists, immunologists, all of these different groups of people debating whether or not this was actually a real disorder, not a real disorder. And I think really the people that got caught in the middle were the children and their families who were suffering from it and couldn't really get any sort of clear direction about how to go about treating it. And this went on for quite some time. And I think the other thing that happened was that the research on pandas really ground to a halt because there was so much controversy surrounding it. I think generally people just didn't want to go near it. And so there really was very little research done for many years on pandas. Nobody could really get funding to do research on it, and it sort of just languished for many years. And finally, in 2010, there was a group of clinicians and researchers that met at NIMH finally to discuss changes to the diagnostic criteria that would hopefully facilitate a more rapid diagnosis and treatment for affected children. And this was really a group of people that were not all Pandas proponents. There were also a lot of people there who were Pandas naysayers, people who really didn't believe in Pandas, who didn't think it was a real thing, who didn't agree with the criteria that Sue Suedo had laid out initially. But they all were able to come together at NIMH in 2010 to try to figure it out, which was a really big step. And I think that they made a couple of concessions that led to a reclassification or a modification of the diagnosis that has hopefully and will hopefully lead to the research pushing ahead. I think the first thing that they were able to agree to at that meeting was that they were going to remove tics from the diagnosis. So remember when I pointed that out in the original criteria for Pandas that tics were included, that had always been, I think, a big area of controversy for people because tics themselves can have an abrupt and rapid onset. And so I think that the inclusion of tics, I think for a lot of people, a lot of researchers and clinicians alike, I think felt confusing, and that caused a lot of difficulty for people. And even though I think if you go back and you read some of Sue Suedo's articles, she really does try to make it clear what she was originally talking about when she talked about an abrupt and sudden onset of tics and or OCD. She really wasn't talking about the sudden onset of a simple motor or vocal tic, which lots of kids do get, and they can be very transient. She was really talking about tics of such a magnitude that oftentimes parents would say, I took my kid to the emergency room because that's how bad it was. But again, I think as a concession, they agreed to remove tics from the criteria. And I think that the other sort of area that they were able to come to agreement about was that they really agreed that the attention should be focused on the clinical presentation rather than on the association with strep. And again, I think that the association with strep over time had been something that had been very difficult for people to kind of wrap their head around, mostly because of the testing issues and challenges. Again, if you can sort of, I feel like as a parent, I can sort of wrap my head around this, that, your kids get sick all the time. And sometimes by the time, you figure out that they're sick and you bring them to the doctor, or they get sick and you keep them home from school for a day or two and then they're better and you send them back to school and, they may have had strep and you never would have known it. And, they go on with their life. And I think that was really what was happening with a lot of these parents, is that their kids may have gotten sick in a way in which they didn't really pay attention to because it was just the way in which kids got sick normally. And then they have this kind of seemingly psychiatric illness that comes on very suddenly, and everybody kind of puts it in a psychiatric bucket, and you forget that they had a fever, 3 days ago, because that seemed very insignificant, and nobody's doing strep testing. And by that time, all this time has passed, and it's too late to do the testing. And, it really made making that connection to strep very challenging. So, so to accomplish these goals, the Pandas criteria was changed to PANS, which stands for Pediatric Acute Onset Neuropsychiatric Syndrome. And, PANS is really meant to encompass the whole group of acute onset cases of OCD. Pandas in and of itself does not go away. It still exists as a diagnosis when those criteria are met. So, there are cases where they have been able to make a clear association with a strep infection, and in those cases, they will still call it Pandas, but Pandas is now sort of encompassed under this broader diagnosis of PANS. So the clinical criteria for PANS, again, the first major criteria, which we've already talked a lot about, is this abrupt and dramatic onset of OCD or severely restricted food intake. And the food restrictions, however, are usually related to OCD and anxiety, things like fears of choking, fears of vomiting, or eating contaminated food. On the far end of the spectrum, they can look like anorexia, but usually don't have to do as much with body image distortions as they do with the fears and anxiety that are more OCD related. And again, the Y-box can increase more than 16 points over the course of 24 to 48 hours. And that while some children may have shown some mild signs of OCD before this kind of dramatic onset with a huge spike in symptoms is really something different altogether. The second major criteria is concurrent acute onset of additional neuropsychiatric symptoms, including at least 2 of the following. So again, this is similar to what we saw in the Pandas criteria, but just a little bit broader. So anxiety is a major one. It can present as separation anxiety, irrational fears, specific phobia. The child can appear kind of terror-stricken, hyper-vigilant, as though they're under constant threat. They can ask for repeated reassurance that they and others are safe. They may do things like ask to sleep in bed with their parents, whereas, again, before emotional lability and depression. They may experience sudden and unexpected changes in their mood. They can change from laughing one minute to crying the next with no obvious precipitant. They can be restless, they can be agitated. They may have abrupt onset symptoms of depression that can be severe enough to include suicidal ideation. And this is especially concerning because these kids can also become very impulsive, so that can be very concerning for parents as well. They can be aggressive, they can be irritable, they can be oppositional, and again, this is really upsetting to parents. I think especially in this category, it can be especially distressing for parents because they will typically describe their kids at baseline as being very good-natured, very sweet-tempered. So this kind of oppositional, aggressive child just seems so different and out of character from the child that they feel as though they, have known and been grown up with. And again, the aggression can occur out of the blue without provocation. Behavioral regression, this can include abrupt increase in temper tantrums, loss of age-appropriate language, since kids can start talking like in baby talk, and just other behaviors that are inappropriate to the child's age and previous stage of development. And again, you may see this in their schoolwork and in their artwork, and I have some examples of that I can show you. And just an overall sudden deterioration in their school performance or their learning abilities. They can have a shortened attention span, difficulties with concentration or memory, other problems with cognition or executive functioning. They can have sensory and motor abnormalities. This can include things like sensitivity to light, to noises, smells, like their clothes don't feel right on their body. They can have somatic and physical signs and symptoms that can include sleep problems and, again, problems with urination, which were not evident before the onset of the symptoms. So, and that we saw that in Pandas as well. The third criteria, again, is that the symptoms are not better explained by a known neurologic or medical disorder such as Sigmoid Tourette's or others. So again, I think what this is saying is that they really want to make sure that they're ruling out other causes for this behavior that people are observing in the child. And they're talking about doing a good diagnostic workup, both a good psychiatric workup, but also a good medical workup. They want to make sure that the symptoms aren't a result of some other disorder, the toxic effect of drug or medication. They can include lab work, EEGs, MRIs, etc. And there is a group at Yale now that is working on the development of a PANS diagnostic and assessment tool that would provide a reliable and valid means of sort of standardizing the diagnostic evaluation of kids suspected of having PANS, which I think would be really useful. Again, I think the problem with Pandas in the past was that people were kind of all over the map in terms of how they were diagnosing it. So I think if everybody could get on the same page with a clear diagnostic and assessment tool, it would be really helpful. So this is just an example of some of the handwriting changes that you can see in these kids. So here is an example of the kid's handwriting before the onset of symptoms and then during the onset. And then here, this is during the symptom exacerbation and then afterwards in panel B. And then similarly here, this is during, this one's hard to see, this in the middle here is during the acute illness, and then after, this is before, it's kind of nice to the outline of the microscope, and then during the symptoms. And these are from Sue Suedo's article. In terms of testing, this also has been the subject of some debate. The International OCD Foundation, along with their people on their scientific advisory board, does recommend a throat culture when a child has an abrupt onset of OCD symptoms, even if they do not have classic strep throat symptoms. But in a Wall Street Journal article that came out, actually now it's been about a year ago, the American Academy of Pediatrics disagreed with this approach and really said that pediatricians should limit strep testing to only kids that had classic strep throat symptoms. So again, there's still this kind of area of controversy and disagreement. But I think the OCD Foundation has really taken the position that if a child shows abrupt onset OCD symptoms, that you should think infection and test accordingly. I think it only seems to make common sense that, doing a strep test seems like a minimally invasive way of testing for infection rather than kind of sending a child down the route of psychiatric treatment when it may not be necessary. So, strep tests are, they're a dime a dozen and people get them all the time. And so it seems like a relatively easy thing to do. And I know, for just anecdotally, that kids show strep infections in a lot of different ways, that they don't always have a sore throat. They often it can look like a stomach bug, they're vomiting, or they just have other kinds of symptoms that are unusual and not typical. And sure enough, when they go to the doctor and get tested, they're strep. So it just seems to make sense. In terms of treatment options, in general, all of the treatment options are minimally studied. So, none of the options have been researched all that well. But more studies are getting underway as there is increased interest in this idea of infection and mental illness increases. But in the meantime, I think clinicians have to use their best judgment to determine safe and effective interventions. So the current treatment options include antibiotics, SSRIs and exposure and response prevention, ibuprofen and non-steroidal anti-inflammatories, and something called IVIG and plasmapheresis. We'll just run through these quickly. Antibiotics obviously are probably the safest and most obvious approach, especially early in the illness, and if strep is present, that seems like a no-brainer. But even in subsequent exacerbations, obtaining strep tests and antibiotic titers and treating with antibiotics is probably the best first route. I think antibiotics are probably the safest and easiest way to go with these kids. And I think when you talk with physicians who treat Pandas children, they will tell you that there's nothing else that works as quickly and effectively as antibiotics in kids with these kinds of infections. So there are really little to no studies, or very few studies, on using prophylactic antibiotics for Pandas kids. Susueto did do a study that showed that there was some improvement when you used prophylactic antibiotics. There have been other studies that have showed that there were no changes when you use prophylactic antibiotics. So, I think that that's just a whole topic for more study. And there is a study sponsored by the International OCD Foundation that actually has started. It's officially started at the University of South Florida. Still trying to get up and going at Mass General about using antibiotics on Pandas kids. And SSRIs are not always a great way to go with kids, especially because these kids can be very young. And Pandas kids tend to be more sensitive as a rule to SSRIs. But if the course continues, they might be helpful, but you need to use them in much lower doses than in non-Pandas children with OCD. So start low and go slow is the recommendation. And exposure and response prevention can be difficult to implement during the acute phase of the illness because the kids are so, they're in such distress. But it is an extremely helpful thing for kids and their families to learn, especially if the episodes continue, because they will need to be able to use it as an ongoing tool. So, but it's usually helpful for them to learn it when they're not in the acute phase of the illness. So ibuprofen and things like naproxen, that's anti-inflammatories. Almost all of the data on this is anecdotal. They think that they might be helpful due to the anti-inflammatory effect on the blood-brain barrier, but again, there's no real studies on these. And then something called IVIG, or intravenous immunoglobulin, has been shown to be effective in small Pandas studies. There was one done at NIH. I think there's one being done at Yale now. And it's generally recommended for the most severe patients because it can be difficult to access. It can be very costly. There are more side effects. It's generally just more invasive. So it's usually reserved as something for the most severe symptoms. Plasmapheresis is sort of like a total plasma replacement, thank you. Which again has been shown to be very effective, but is even more invasive than IVIG. So I know we're sort of running out of time, so I may actually, I'm going to talk about this case because I think it's just a good way to wrap up. I think that even for myself as a person who doesn't necessarily treat children, I think that learning about Pandas and knowing about Pandas has been important to me just in the way that I approach my daily work. And I use this example because this was a guy from Connecticut, a man from Connecticut emailed me about his 6-year-old son. And I get emails like this like all the time, every day. And all he said was, I have a 6-year-old son who has OCD, and I know you don't treat kids at McLean, but I'm just hoping you can kind of point me in the right direction because I don't really know what to do, and could you help me out? And, normally I would have, sent him in the direction of psychiatric treatment providers in his area and talked with him about exposure and response prevention and those sorts of things. But at the time that I received this, I was sort of preparing for this talk, and I gave this talk about a year ago, and it occurred to me to ask him if his child had been sick recently, and if the symptoms had come on abruptly, or if he had had them over time. And he got back to me and he said, well, yeah, he has been sick. He had a cold or a fever, and the symptoms came on very abruptly, right after that. So I pointed him towards the Pandas page on the International OCD Foundation website, and he wrote back to me and said, I cannot believe how much this description fits my child like almost to a T. He took him to the pediatrician, they put him on antibiotics, and 2 weeks later, the symptoms had totally remitted. And so, it was so instructive to me, because I know even for myself, in another, 6 months earlier, I would have kind of given this guy completely different advice. And, here was a kid who may have been sent down a totally different road, but yet 2 weeks later, his symptoms were gone. And, I think that is where I think, I feel like you can know that this really is a real, it's a real disorder, and that there are different treatments for it than traditional OCD treatments, and why, we all need to do our part to raise awareness about it, so that children and families don't have to struggle endlessly and for many years when they could have had remission in 2 weeks. I think that's just kind of heartbreaking. So Tom Insel, who's the head of NIMH, sort of had this quote that really talks about, again, I think the future of this whole field of infection and mental illness, because I think it doesn't just pertain to OCD, I think it pertains to other mental illnesses as well. And I think we're really just on the forefront of this. We're right on the cusp, and I think that most likely we will find out that, these kinds of issues were really, right in front of us all along, and hopefully that now that we've removed some of the roadblocks, the research can move forward and people can benefit from that in the future. So again, I want to make sure I leave a couple minutes for questions. Denise? Yes, Denise, in the back.
So I'm treating a kid now. His mother said 4 years ago this all happened, and so do you think that he could be taking antibiotics now and get symptom reduction, or is it something that there's a window of time that people need to act in?
Yeah, I don't. How old is he?
It's like 12, 13, yeah.
Maybe. I mean, I think the question is really more about when they're still kids,
yeah,
and if they're still kind of having these exacerbations, whether
catching
taking antibiotics then would help.
Yeah, catching the spike.
I always feel like it's worth a try. I mean, I think a lot of times people ask that about adults, like many years later, and I think we've even tried that, and we haven't really seen a big improvement in adults when you try to do that. But I think in kids, especially if it has been like a really, even 4 years, I don't necessarily consider a really long time. It would be worth a try.
Yeah.
Do you know anything about adults or younger with OCD having a tendency to have low white blood cell counts?
No.
Well, I know that some patients in some groups and some leaders of groups have noticed that. I don't know if you remember, there was a woman who led an adolescent group here at one time, and she noticed it in her adolescent group, and I've seen it among adults.
Yeah. That's
which is sort of a chicken egg thing, like,
Yeah, right.
which came first.
Yeah.
And I've also known a guy who was tested at around age 35 for his antibodies in his spinal cord fluid. And he didn't expect to be able to treat it now, but he wanted to know if he had strep in the past.
Mm-hmm.
And they were able, apparently, to find that out
Oh, yeah.
that much later.
I had strep throat when I was 10 years old, and it wound up in my kidneys infection. Now, I started with my OCD 8 years ago. Now, this was over 60 years
Mm-hmm.
later. Is it possible that now, with adults, the same thing could be happening, that they're getting strep and they will get the OCD like they're talking about children?
Yeah, I honestly don't know. I mean, I think that they've really been focusing on kids primarily because, that's, when they're really developing these antibodies to the strep. Usually when you're an adult, you sort of develop this kind of, immunity in your body. You had strep, your body's sort of been used to fighting it off. But I don't know whether they really think that adults get Pandas, but I don't know that they think that they don't. I think most of the studies have been focused on kids. So to be honest, I don't honestly know if they think adults in general.
So I was just wondering if at 10 years old, I'm not showing symptoms until in my late 60s.
Right. My guess is with that long of a time span, it probably was not related. At least according to like what they're talking about now is that, typically the acute symptom onset follows the infection fairly closely.
When she was young, she went through from 3 years old to 8 years old, constantly with infections, constantly with ear infections, strep, turned to scarlet fever, and then she had that actually twice. When she was born, she was actually diagnosed with an infection in her liver. She was hospitalized for it, and it was unexplained. So we ended up taking her to different allergists until eventually they stripped everything out of her diet. No dyes, no perfumes, nothing. And she was becoming allergic to antibiotics, where there was only 2 antibiotics she could ever take. Is that something that now at this age where she's got these signs and symptoms of OCD that could be a factor?
Again, it's very possible, and I think that, these are the other kinds of stories that I feel like I hear all the time, these sort of nice, neat packages, where, I think the symptoms, you get an infection, and then 2 days later you have, you get the symptoms. I think, those kinds of cases definitely happen. I think then you also hear about these much more complex cases like this, where there's, multiple kinds of infections going on, different kinds of allergies going on, and the relationship between that and, any sort of mental illness, I think is definitely up for grabs. I think it's almost, it's impossible to know, but definitely, I think you can't.
And she had constant high fevers.
Yeah. Yeah.
Does family history matter at all? Are they finding, I know this is all brand new, but are they looking at these Pandas kids and saying, well, there's a family history of OCD and so they're more susceptible to this?
Yeah, the whole issue of susceptibility is I think they don't really know what makes people susceptible, but I think they're trying, that's one of the things we're focusing on, is trying to find these genetic markers to figure out why in some people these antibodies are able to cross the blood-brain barrier. Is it a genetic thing that allows that to happen, or is it something else, Yeah.
I have time for one more question.
Is there any research, she was talking about allergies. Do you know of any research where they're asking kids if they have any allergies? You know, comparing whether they have OCD and,
Right.
or any mental illness, I guess.
Not that I know of.
Okay.
Yeah, and it's funny, like even in adult patients, you know, I think it's hard to remember
Yeah.
whether, I mean, sometimes I think parents remember, but I think it's hard for you to remember when you were
Right.
5, whether your onset was acute or not,
Right.
you know, so.
Okay, thank you.
Thank you, Diane. So Diane, you mentioned the International OCD Foundation website has a really good page on Pandas. So if you have more questions about it, you should go there. I recently read it and it's really good information. But all of this stuff is really just happening. Like, you know, the IOCDF people and NNMH people, they really just met and they're really just getting their stuff together and research is really just starting. So I think what we'll do is next year, maybe we'll have Diane come back and do an update so we can see a year later what's really happening. But these are some of the questions that we asked tonight are questions that you're getting asked a lot, I'm getting asked a lot. And so maybe we'll even recommend that they like an FAQ on the IOCDF website for some of these, to answer some of these very commonly asked questions. So stay tuned for that kind of information too. See y'all next month.